Good afternoon and welcome back to everyone to what's going to be a very exciting keynote. It's my great pleasure and honor to introduce David McDermott. David doesn't need a long introduction. I'll keep it short in spite of his long list of accolades. He's Chief of Medical Oncology at Beth Israel Medical Center. He's Director of Cutaneous IO Program, Co-Director of Cancer Center of Immunotherapy Institute. He's NCI co-director of Kidney Cancer SPORE, and if that wasn't enough, he's professor of medicine at Harvard Medical School. I don't need to tell you that David's had a profound impact on our understanding of kidney cancer, especially in the context of targeted immunotherapy intervention. So without further ado, I'm very excited to hear what he's going to share with us today. David, welcome and thank you.
Thank you, Salma. I appreciate the invitation and the kind introduction. I was so honored to be named a keynote speaker that I thought about wearing a tie for this talk for the first time in over a year, but then of course I forgot it at home. So I apologize for being a bit informal. So the work I'm going to be talking about today is the work of many other people that some of which I'm fortunate enough to work with at the Dana-Farber Harvard Kidney Cancer Program. And then many of you in the audience that are responsible for much of this progress, which has truly been exciting. What I want to talk about today is the concept that kidney cancer is actually curable and that we should try to move the field in that direction to create more cures of advanced disease. So it's also nice to be talking in front of a mixed audience. And what do I mean by that is not just scientists and medical oncologists, but also surgeons. Because much of what we focus on here at Beth Israel was work that was originally developed by surgeons, by folks like this gentleman here, Dr. Steven Rosenberg at the National Cancer Institute Surgery Branch. This picture is almost 35 years old. He's still head of the surgery branch. And it was there that a lot of this sort of early days of solid tumor immunotherapy were built, initially around cytokine therapy, and proved a very important concept that you could treat patients for a short period of time with a therapy, in this case, to boost their immune response to an established cancer and create dramatic effects that would last for years, here 10 years. But because the treatments are pretty toxic, these treatments are pretty toxic and pretty ineffective in most patients, this early advance sort of stalled. When I started, working, in this area, pretty much very few people were at all interested in immune therapy, and things have certainly changed. They've changed largely due to our improved understanding of how the immune response is defeated by cancer. Most of the patients that we see in the clinic are in a setting of immune escape. They have established cancer that's spread to multiple parts of their body. The goal of most solid tumor immunotherapy is to actually eliminate all cancer. So trying to push patients hard to get all their cancer to go away. I think through the insights of people like Gordon Freeman and Dr. Hanjo, we have a much better understanding of how the immune response is regulated and how we can overcome some of the defense mechanisms of the tumor with PD-1 blockade. But for the most part, single agent PD-1 blockade, as you know, in kidney cancer and in many tumors is partially effective in the sense that it's on the one hand, it's changed the way we look at and treat many different cancers, but most patients don't get elimination of their disease. They get a movement towards equilibrium where there's control over the tumor, and eventually the tumor figures out a way around that block. So in hopes of sort of improving outcome, many folks in the kidney cancer space, we talked about this earlier this morning, and obviously in other tumor types have tried to come up with different combinations to try to essentially enhance the anti-tumor immune response to see if we could, amplify the responses we're seeing with single agent therapy. The most commonly applied, as Dr. Rini talked about earlier, is essentially the fusion of first and second line therapy, the old first line, the old second line together with PD-1, VEGF blockade. And despite the fact that these two esteemed gentlemen were part of this result, it was quite impressive, as you know, and sort of changed our thoughts about what was possible in the front line, showing that you could have a 50% reduction in risk of death early on with the combination of PD-1 and VEGF. and has made, obviously this paper made a lot of advances and it's been followed on by several other papers, several other investigations that you've talked about this morning and this afternoon. So the other approach, as you know, is PD-1 CTLA-4 that has its pluses and minuses, which we can talk about, and you've already talked about a little bit today, so I won't belabor them. But essentially where we're at right now is sort of a situation in the field where we spend a lot of time talking about these trials and essentially trying to address the question of which regimen should be favored. I think, as Brian mentioned, there are pros and cons to all of these approaches. High early impact, particularly in symptomatic disease for patients getting PD-1 and VEGF. Now with more follow-up, you're seeing more durable responses with PD-1 and CTLA-4, but also importantly, you're seeing the potential to stop therapy. So this harkens back to the days of high-dose IL-2, where the treatment can be short and the benefit can last after you stop treatment. The same, for say allogeneic stem cell transplant, for example, PD-1 CTLA-4, at least in some kidney cancer patients, is achieving that elimination of disease, I believe, and that's in part why we generally favor either single agent PD-1 or the combination for frontline therapy. And I think we could spend a lot of time on this debate. I think, and most meetings we do, I would argue, though, for purposes of this discussion, that this debate is largely a waste of time for a variety of reasons. One, as Brian pointed out, cross-trial comparisons are obviously flawed. The trials have very unequal follow-up durations. So what we're seeing emerge in Ipi/Nivo, we might start to see in some of the VEGF combinations as they get more mature. Can we stop treatment? Can we see benefit after treatment stopped? Let's see. We'll see if that happens. But also, in part, I don't think we agree as a field on what the most important endpoints should be. And I think we should spend some time thinking about that and how we can do better. And what do I mean by that? Well, when you think about clinical trial endpoints, I think it's important to consider, which endpoints are most important, which endpoints should rule, essentially. We spend a lot of time focused on early endpoints, what I would define as, at least in kidney cancer, outcomes that occur in the first 2 years after starting treatment. These are generally favored by industry because they help with getting drugs and combinations approved. They are certainly important for symptomatic patients, no question. So if I have a symptomatic patient with metastatic disease, I'm giving them VEGF PD-1. But there are other endpoints which are also, as we're starting to see with Ipi/Nivo, also important. And these are late endpoints, the ones that develop often after 2 years. These are endpoints often favored by our surgical colleagues and by our stem cell transplant colleagues. They're looking for long-term benefit. They're looking at duration of response. They're looking for landmark progression-free survival. I mean, how many of their patients are free of disease 3 years, 5 years, 10 years later, and obviously long-term overall survival. And then there's this third group of endpoints, which I would call durable endpoints, meaning those are the endpoints that we can see with certain forms of immune therapy that continue after the treatment stops, much like a surgery benefit. These are favored by lots of our patients, and we are trying to measure them with a new endpoint, which we are calling treatment-free survival, which I'll spend some time talking about. I think other issues for the field that we need to consider when we, not to try to compare these regimens, but I think one important thing to think about is what are the best platforms on which we can build. When you look at the PD-1 VEGF data, I think one trend that you see, and you're starting to see this in other data sets, is that the endpoints don't stay stable with time. They were excellent hazard ratio here for overall survival early. That's not as great after 2 years of follow-up, where we're starting to see a flattening of the survival curve, for patients getting PD-1 CTLA-4. You can see in Laurence's recent ESMO Open paper, you see about half of the patients alive at 5 years, or 4 years, I think, which is very encouraging. On top of survival, progression-free survival is also important, and I think in some ways shows the true impact of the initial therapy. Here you're seeing a plateau at around north of 30%. You're not yet seeing a plateau here. I would predict, I think, hard to know, that this plateau, if it exists, is going to be less. But let's see what happens. Initially, right now, when you're trying to decide which is superior, I think early endpoints favor VEGF, late endpoints, at least now, favor CTLA-4. And one thing we'll get to at the end is I think durable endpoints, meaning the endpoints that happen after treatment is stopped, probably favor CTLA-4 based combos now. But we have to do the work. We have to do the comparison, and we will going forward. I think one of the reasons, though, this debate, an additional reason why this debate is not worth our time, is the field is changing really rapidly. So we're talking about combinations now, combinations that are not yet available in many parts of the world. Some of them are going to be even less available when pembrolizumab PD-1 blockade becomes available in the adjuvant setting. Based on the Keynote 564 trial, once again, earlier this month, some recent data, we haven't seen it all. We obviously need to see the details, but, if this comes to pass and we see PD-1 blockade approved, we'll probably be able to, we'll be seeing a lot of patients in the metastatic setting who've already seen PD-1. So what works there? That's obviously a huge question for the field. But combos are probably not going to get us very far for those patients. So first line therapy, doublets, may not be the standard for very long, particularly not just with adjuvant therapy coming, but with a triplet therapy probably finding its way into the front line as well. But I think the more interesting question, and the question we should focus on, and I'll try to spend the rest of my talk on, is not which regimen is better in the front line. But it's this, which is, do you believe that advanced kidney cancer can be cured? Yes or no? I think many clinicians, clinical oncologists in the community, at least in the US, think the answer to that question is no. I think the data suggests and has suggested for a while that the answer is yes. And if you believe the answer is yes, then what we should do as a group is to try to work to make these cures more common. I would argue, and this may sound a bit ridiculous, that kidney cancer is essentially now in 2021 where testicular cancer was in 1981. This is a paper from Dr. Einhorn, who's obviously one of the founding folks who drove the therapy of testicular cancer to great success. And this is his paper, Testicular Cancer as a Model for a Curable Neoplasm. And he was essentially arguing 40 years ago that we're seeing cures, let's work to see more cures. And I think that's where we're starting to see that data now in kidney cancer, and we should work to improve it over time. How are we doing that here at DFHCC? A lot of you are involved in this work at other centers, so I don't want to suggest that we're the only ones doing this, but we're still trying to rationally apply immunotherapy. I think in some ways we've gone from an era where no one cared about immune therapy to now overreacting and giving immunotherapy in every scenario, even to patients that will never get a benefit from immune checkpoint blockade. So we still must insist on the rational application of these drugs, particularly when we get to the adjuvant setting, which I can talk about in a second. One of the efforts to try to understand kidney cancer biology that was led by Genentech, which I think is really important for a variety of reasons. This was not an effort to try to create predictive biomarkers. It was just an effort to try to understand, how did biology relates to outcome. And there was a lot of time and a lot of effort invested by Genentech and their scientists who are shown here. And it I think, helped improve our understanding of kidney cancer biology, and it led to the phase 3 trial, which was obviously in some ways disappointing clinically, although the results in hepatocellular cancer are awesome. Brian talked about this earlier, but it's this work that was expanded on from the phase 2 to the phase 3 that I think is, sort of a roadmap for where we need to go, particularly in the adjuvant setting. So you may argue that as regimens become more complex, it's going to be hard to select for metastatic patients. But it's even more important to select and try to identify these patients who are more likely to benefit from checkpoint blockade in the adjuvant setting, because there the risk-benefit ratio is really against bad outcomes. You really cannot be exposing patients to toxic therapies if they have no chance of benefiting. So even though we don't feel like we're on the verge of biomarkers for metastatic patients, we still need to push hard to get this work done. I think Genentech deserves some credit for doing that. We need to push other industry sponsors of these trials to do that work, so we can get answers on who should get immune checkpoint blockade and who shouldn't. Because there are many patients that are not going to benefit, meaning essentially if you do not have a pre-established immune response in your tumor, you're going to get a very limited benefit to immune checkpoint blockade. But the other approach that we need to consider are novel trial designs. We talked about adjuvant therapy earlier. I think this is one of those trials in the adjuvant setting when Chuck Drake originally proposed this concept of pre-surgical PD-1 blockade. People thought he was nuts. Naomi Haas and Lauren Harshman have driven this effort from the beginning, and it's coming to its fruition as far as accrual goes. But this concept of pre-surgical PD-1 is actually gaining hold in other tumor types. So if you look at the data in lung cancer, giving a dose or two of PD-1, in this case nivolumab, before a surgery actually produces dramatic complete pathologic responses in those tumors. And Chuck, it looks like he was right in the sense that the drug here is the immune cells. So why don't you give the PD-1 when the immune cells are highest in the tumor, when the tumor is still in place before surgery, when the tumor antigens are highest? And now we finally have randomized data from AACR a couple of weeks ago suggesting that, we may be onto something here. So maybe novel designs, can help us improve outcomes for our patients. I think other approaches to making cures more common, obviously developing novel targets. Up until now, we've been targeting mostly the tumor microenvironment with VEGF and checkpoint blockade. How about targeting the tumor? You spent time at this meeting talking about HIF-2 alpha, obviously an important transcription factor in clear cell kidney cancer. You were seeing early encouraging clinical results. But one of the questions we're asking is, does targeting HIF-2 actually enhance the immune response to the tumor? I don't think we know the answer to that question as a field. I think the early data with PT2977 and Nivo is, not that exciting. To be honest, we should try to address this question instead of going full on into doublets and triplets with HIF-2 before we understand that question. But in the ideal world, targeting HIF-2 would be a solution to a lot of the problems that kidney cancer generates in the tumor microenvironment. If you believe the preclinical data, HIF is a driver of a variety of different biologic mechanisms, many of which are probably immune suppressive. So the early clinical results, just published last night, the phase 1 results are encouraging. Can we build on it? Can we snuff out HIF-2 signaling even more than we're doing with belzutifan single agent alone? One approach that the Kalin Lab has taken is looking at targeting HIF-2 through synthetic lethal interactions. They believe that in preclinical models, CDK4/6 has a synthetic lethal interaction here in tumors that are VHL null. And early clinical trials are starting looking at CDK4/6 as a single agent in kidney cancer, and hopefully soon in combination with HIF inhibition as well. But we need to understand much more in the human, not just about what works in combination with HIF-2, targeting the pathway more, but also exploring resistance mechanisms. Another way of potentially targeting HIF-2 might be vertical inhibition of HIF-2. So we focused a lot with belzutifan on direct inhibition. Could we destabilize HIF-2? The answer is maybe. Another approach stems from this discovery that thalidomide-like drugs destabilize the transcription factors EIKCS1 and 3, which act as oncoproteins in multiple myeloma. The assay that was used to develop this investigation is now being used by the Kalin Lab to look for small molecules that might destabilize HIF-2 in the absence of VHL. So maybe through direct inhibition and destabilization, we can get more inhibition of this pathway and hopefully more greater effect and more enhancement of the immune response to the tumor. Another thing that many of you are doing that we're also trying to do is to try to interrogate the tumor microenvironment to develop new therapies. And I'll talk a little bit about some of those approaches. This is work with single cell RNA sequencing. Obviously, Samra's group has done a lot of groundbreaking work in this area, and she had a terrific paper on this subject. Many groups are finding very similar things. This is work from the Wu lab that David Braun led in collaboration with people like Sabina Signoretti and our group, essentially looking at single cell sequencing, finding, maybe not surprisingly, that immune dysfunction increases with stage, that this exhausted phenotype is associated with poor outcome. But also through this work, maybe there's certain targets that might be worth hitting, that we're seeing some targets develop over time that now can be drugged. So for example, TIGIT may play a role in this exhausted phenotype. That can be drugged. Now, single agent TIGIT blockade has pretty minimal activity, but now in combination with PD-1, we do have at least one randomized trial, I believe in lung cancer, showing it may add something. So could we do that in the right patient in kidney cancer? It's certainly worth exploring and trying to target M2 macrophages, which seem to have a role in tumor-induced immune suppression, also makes sense. You hear a lot about vaccines. They're not to spend too much time on this, but essentially what we're learning from the single cell data is the earlier the better. So these are not likely to have as much of an impact in the metastatic setting. So now Tony and David and others are moving their neoantigen vaccine platform that Dr. Wu developed into adjuvant trials for kidney cancer. Another interesting approach has been, sort of developing novel checkpoints. This we think is one. So this is the HHLA2 pathway. Prior research in this field suggested that the HHLA2 interaction was actually immunostimulatory. The Bott and the Freeman labs have actually identified a new receptor, which they believe is immunoinhibitory, that they think in preclinical models that they can drug. So by doing that, much in the way you might drug, say, CTLA4, you might be able to enhance the immune response. And one of the things that Sabina's group has shown is that HHLA2 expression it's expressed in the majority of kidney cancer. And expression, interestingly, is non-overlapping with PD-L1. So maybe this pathway contributes to resistance to PD-1 blockade. So, in the preclinical models, this inhibitory signal can be reversed. And we're trying to now they're trying to optimize agents for human testing, hopefully in the coming years. So once again, trying to understand, what are the drivers of resistance to immune therapy to develop novel agents. And in the last, 10 minutes of my talk, what I wanted to focus on is sort of this concept of novel endpoints, how we might use them to actually improve outcomes for our patients. We've heard some of this in this meeting so far about how depth of response is associated with long-term survival. We certainly saw that with high-dose IL-2, and that's the endpoint that essentially led to its FDA approval 100 years ago. What do we see with PD-1 CTLA4? Well, looking at depth of response, it does seem connection. This is Victor Grunwald presented this at ESMO a couple of years ago, looking at, not surprisingly maybe, the deeper the response, the more likely you're able to be alive at 3 and 4 years. In building on that, this sort of begs a couple of questions which we can talk about. Like, for example, do we need to treat these deep responders as long? Can we stop their treatment sooner? Another endpoint we're looking at is so-called treatment-free survival, which is being developed, not necessarily to prove that immunotherapy is awesome. It's designed to look at both the pluses and the minuses of immune therapy. As many of you know, we can see durable benefit after treatment stops, so-called treatment-free survival with checkpoint blockade, but you can also see durable toxicity and late toxicity. So we tried to develop this endpoint. Meredith Regan led this work, looking at the treatment-free survival with and without toxicity. And she's published that in a melanoma. What do we see when we look at kidney cancer? Well, here's a look at PD-1 CTLA4 versus VEGF. and the Checkmate 214 study. You obviously know the survival data. What do we see in treatment-free survival? Well, for intermediate and poor risk patients, you see overall survival is better, but treatment-free survival is twice as long as with sunitinib. And if you're looking at just grade 3 toxicity alone, you're seeing very similar amounts of grade 3 toxicity, somewhat less with sunitinib, but you're not seeing a negative trade-off for trying to be more aggressive when it comes to grade 3 toxicity. Well, one of the questions we get a lot is, what about favorable risk patients? This is what we saw when she looked at that. So this obviously overall survival in that group is identical at the moment with sunitinib, but you see 3 times more treatment-free survival. But there are trade-offs. Here, looking at grade 2 toxicity, you see much more light blue. So the off-treatment tox is greater with ipi-nivo than with sunitinib. So we believe this tool will help in that discussion, an initial therapy of, what are the pluses and minuses of dual checkpoint blockade, and going forward, it'll help us understand whether we're on the right track with these approaches. In light purple, you see this is on-treatment toxicity. Look at all this on-treatment toxicity with sunitinib. So it shows the pluses and minuses of both approaches. And sort of, as we move towards triplets in the field, this is the COSMIC 313 study. Can we use treatment-free survival to help us interpret the result of that study? Now, obviously that we don't know the result of that study, but I would predict maybe ESMO 2020, when hopefully we can all get together in person again, Laurence is going to stand up there at ESMO and say the following with this study. She's going to say, progression-free survival benefits the triplet. So Nivo, Ipi, Cabo wins on the primary endpoint for progression-free survival. I would say that over time, we'll say overall survival was pretty equal, between those groups. But if you looked at treatment-free survival between these two groups, which would be interesting to do, my guess is treatment-free survival is going to favor Nivo, Ipi. And then it gives you, that sort of adds an extra piece potentially. Now this result may not happen because many of the things that I say turn out not to be true, but it gives us an extra way of interpreting the data, and an extra way of advising our patients going forward. And it gives us maybe a sense of, are we going in the right direction with immune therapy? If our goals are cures and more treatment-free survival, is regimen X moving in that direction? And a lot of it, that's why, it depends on what our goals are. And sort of how can we improve treatment-free survival? This is a model that is often described as finished, but it's a work in progress. We're still trying to incorporate quality of life and cost into this model. We'd love to compare these two approaches to get, a sense of whether TFS can help us decide what to do first line. We'd also like to test this prospectively. We certainly need to do that. But probably the more interesting question is, how do we create more treatment-free survival? One way, and the Cleveland Clinic folks have taught us this, is we could just not treat patients. We could just observe them, have them live, particularly good risk patients, off treatment. We could also stop the treatment early. That would improve treatment-free survival. And we can try to push for deep responses, which I'll talk about in a second. Going back to the concept of novel designs, Dr. Zhang and Dr. Schwery have designed the Pedigree trial, which is enrolling patients. And they have they're looking at a novel question: is in certain patients, can you discontinue treatment? What happens when you discontinue? The hope would be, at least in deep responders, that the benefit would continue, thus increasing treatment-free survival. But getting back to this question of pushing for deep responses, I wanted to return to where I started on this curable neoplasm person, Dr. Einhorn with testicular cancer. When they started to see deep responses, remissions, cures of testicular cancer, that became the goal. So if you go now and look at the very complicated NCCN guidelines for testicular cancer, if patients don't achieve that goal or don't look like they're going to achieve that goal, the response in many patients, not in all patients, is let's get more aggressive. Let's try more intensive therapies to try to reach that goal, like high-dose chemo and stem cell rescue, for example. I think one question I would pose to the group is, should we be doing that for some kidney cancer patients? In our PD-1 failure patients, should we propose, say, CAR T-cell therapy or something else in that setting to try to push for more remissions? One approach that we're trying, we hope to try in kidney cancer, is TIL therapy, or so-called a tumor infiltrating lymphocyte therapy. Once again, a therapy invented largely by surgeons at the National Cancer Institute. This is a very aggressive approach that requires surgical intervention, resecting the tumor, non-myeloablating the patient with chemotherapy, and then reinfusing the TIL, and then adding to that the high-dose IL-2, although less intensive than regular IL-2. All of this is still pretty intensive, but the goal there is to try to produce remissions of disease. And this approach in melanoma has about a 35% response rate in small trials in patients who failed PD-1 and CTLA-4. So we're hoping to try to develop this in kidney cancer going forward. One of the things we need, and Tony alluded to this in his talk, is better markers of response, a better sense of who needs therapy, who do we need to be more aggressive with, or not? Who do we need to consider adjuvant therapy with, or not? And we're hoping, and he talked about this, so I won't belabor this, that ctDNA might be that. Could ctDNA be the beta HCG for kidney cancer? Well, let's find out. Let's look at other markers, like Dr. Bott has looked at KIM1 with Dr. Bonventry here at the Brigham. Is that a potential marker? Are these soluble markers that helpful in the clinic? Are they more helpful than scans, for example, or clinical factors? I think we should push. We should push really hard to try to figure out the answer to that question, because I think it can obviously help us guide therapy more reliably than we're doing right now. This is one of our patients. He's a guy with stage 4 kidney cancer who was on that original Emotion 150 study and is now in remission of his disease. He is now, in this picture, he's jumping off the tallest bungee jumping platform in the world. So he is both living in treatment-free survival and trying to shorten his life at the same time, which seems like, a crazy thing to do. But hopefully we can create more outcomes like this. And I think we can if we work together and we insist on novel trial designs like Prosper, like Pedigree and others. We insist on focusing on novel targets, not only targets like potentially TIGIT and HHLA2 that we might learn from the tumor microenvironment, but also targeting HIF and trying to address the question, does targeting HIF amplify the immune response to the tumor as we potentially imagine combinations with IO therapy. Also focusing on novel endpoints like treating to depth of response and treatment-free survival, landmark PFS. Let's focus more on those because now we can achieve those. And also novel algorithms, like should we treat kidney cancer more like testicular cancer? I think if we want to see the outcomes they see in that disease, we need to do that as a group. And we need to insist on developing novel endpoints and novel outcomes so we can produce more responses like this gentleman here. So that when we meet again in 10 years, the therapy is identified based on treatment based on the microenvironment profiling, not giving IO therapy to every patient. And second-line therapy will be increasingly unnecessary because more patients will be cured of their disease. I want to acknowledge all the people that have contributed to this work. And these are the folks that I'm lucky enough to get to work with in Boston. And I look forward to your questions. Thank you very much for the honor of presenting today.
Well, thank you so much, David. That was fabulous. And I think it's really motivated us all, including the audience who've come in with questions. So let's move on to those. We've got about 10 minutes. Freddie, did you want to start us off with the questions from the audience?
Yeah, I can find the first one. Can you say a few words about prevention in this disease?
The short answer is no, but I think it's important. I think obviously the two biggest things we could do to improve outcomes for kidney cancer patients were A, prevent its establishment, and B, detect it early. We are trying to look at those connections. There are obviously some risk factors, as all of us know, for the development of kidney cancer. So, for example, if we eliminated, tobacco smoking, I think if we regulated tobacco as a drug, which it is, we would see a reduction, in kidney cancer incidence, that's for sure. We're looking at the interactions between kidney injury and kidney cancer. We have some investigators. We're lucky enough to work with some nephrologists who are trying to look at those interactions. That's where some of this kidney injury molecule work comes from. So I think that work is important, but I don't think we're on the verge of a major breakthrough that will decrease the incidence. I do think, though, we are much more likely to come up with tools to detect small amounts of kidney cancer and give our surgeons a better shot at removing kidney cancer early. I can't think of a disease that we'd see more of an impact than an early blood or urine marker, particularly in high-risk patients, for development of kidney cancer, because those tumors can, as everyone knows, can get really big before they're metastatic. We're trying to understand, and Tony's leading this work, does, for example, ctDNA, is it as predictive in urine as it is in blood? We're looking at different groups of patients in that regard. If it turns out we can improve its detection in urine, that may be a way of getting this early. And if we can get it early, we know we can cure more patients. I think that'll be should be a major focus of the field.
Thank you, David. We actually have a question from the audience from a kidney cancer survivor. So as a survivor of kidney cancer stage 4, now 17 years, cured thanks to high-dose IL-2, I must ask why this is not used more often.
Oh, that is a good question. You should add, that question shouldn't go to me. It should go to the investigators in the audience. I think it would be better. The honest answer to that is that IL-2, while it can work brilliantly, and it's a great thing that it worked brilliantly in this person's case, doesn't work for most patients. So even in select patients, 9 times out of 10, it doesn't produce durable remissions or cures. And it's associated with, dramatic toxicity. And we failed as a group to identify those patients who might respond beforehand. Failed is a strong word. We didn't succeed in doing that. I think if we had a better marker for who benefits from IL-2, you would see it used more, because I think if the response rate was higher, if the cure rate was higher, people would use it. But it's interesting, IL-2 has been criticized for most of my career. I got invited to give the IL-2 talk, and most of the people were talking about something else, that was much more interesting. Now IL-2 is making a little bit of a comeback. It's making a comeback in some of these T-cell products. It's making a comeback with novel forms of IL-2. That may be certainly less toxic and maybe more active. We'll have to see. They're certainly worth testing, but there's still hurdles. But part of that gets around to what I was talking about before. If we all assumed that our goal was curing more patients, we'd be willing to pursue some of those aggressive approaches. I don't think most oncologists look at kidney cancer as curable, so they're not willing to push. The way we are in testicular cancer, no one would argue that you should get aggressive in certain testicular cancers. We do spend a lot of time arguing about that in kidney cancer.
Yeah, I mean, certainly hematologist mindset
Right.
with bone marrow transplant is
right.
doesn't ask for 100% success rate.
Right, and they are also looking at low volume disease, and if they see it, they're treating more aggressively. I think that we have the capability of moving in that direction for certain patients. It's obviously, I don't want to over exaggerate what you can see with these immune therapies, because for most patients they're disappointing, but we should be pushing harder in the appropriate patient, I think.
So maybe I'll jump to a related question and then back to Freddie. How will adjuvant therapies affect first-line treatment choice? I think this is on everyone's lips.
Right. So I went through that pretty quickly, but I think it turns everything upside down. If a third of your patients, let's say, to pick a number, are already PD-1 exposed when they become metastatic, in many parts of the world, you're not going to be able to give subsequent PD-1 therapy. There's not, at the moment, there's not randomized evidence that a PD-1 regimen, single agent or combo, salvages that scenario. We need to do those trials. We need to do a lot of post PD-1 work. I think in my general sense from melanoma, which is not, perfectly, it's not a great, a perfect comparison, but we are giving PD-1 based therapies to adjuvant patients if the distance between the initial adjuvant therapy and the recurrence is sufficiently long. Now, that is sort of arbitrary. Some people say a year, some people say 2 years, because in that scenario, you might have a PD-1 deficiency syndrome, but if someone recurs or grows through PD-1, there's no proof that PD-1 salvage works or PD-1 combo works in those patients. Investigators should be forced to prove that it does. We shouldn't accept just off-label use of agents. We should insist on trials.
Thank you. Freddie.
Yeah, thank you for a fantastic presentation. I have a question about physical activity. Can you say a few words about that?
Not anything super intelligent. I think in general there's a connection, and Laurence could speak to this, Tony could speak to this, potentially between obesity and the incidence, the likelihood of getting kidney cancer. There's a debate on whether those kidney cancers are more or less aggressive when they develop. I think in general, fitness, less obesity would probably reduce some kidney cancer incidence. I can't prove that. That's about what I know. It's certainly not, doesn't make a huge impact once the cancer is developed. At least in my experience, oftentimes patients will decide once they have advanced disease that they're going to eat better and exercise more. I'm not sure once that has happened, it makes a difference, but we haven't studied it formally. We could, but we haven't studied it formally.
Yeah, we could.
David, I just want to get to a couple of remaining questions from the audience.
Sure.
And I'll read them out both, and then hopefully you can get to them both. So the first is MSD is claiming that HIF2 alpha inhibitor has blockbuster potential in RCC. Do you agree? And the second comes from Saeed Dabestani. Will surgery still have a role in curing kidney cancer in the future?
Okay, two good questions. I think the short answer to the first question is no. I think it's a major advance to prove that HIF2 is a driver of clear cell kidney cancer. So that was something that people debated, and now you have a drug that is well targeted. You see clinical activity. So you have proof of principle that HIF2 is important for certain kidney cancer patients. But just blocking it with belzutifan is not, when I think of blockbuster, I think of remissions, high response rates, ability to stop the treatment. We're not seeing that with single agent therapy. We're seeing good tolerability. You might see more with combinations, but I think we can push the envelope, as I was trying to allude to, on the pathway. So, we can add other combinations horizontally. We potentially could target HIF in multiple different ways. I think it's sort of proof of principle. We should do more, but it's not, I don't think it reaches blockbuster status. And if anything, the phase 3 trial, given where it's being tested, might show less clinical activity than we've seen in the very selected patients so far. And we should be prepared for that, but we should still build on it, build on it in well-designed trials. And I think, honestly, a well-designed trial might not be HIF plus PD-1. Until we know that HIF inhibition amplifies the immune response, well, HIF plus PD-1 may not be the right thing to do. And there's some people who argue that it could be a negative thing to do. So let's do those studies, before we make those assumptions. As far as surgery and its role, I'm not a surgeon, maybe I'm a wannabe surgeon, but I think surgery has an enormous role in the treatment of kidney cancer, and it will only increase. Whether we like it or not as medical oncologists, we're going to have to share more of the clinical decision-making with our surgical colleagues. Now that we have adjuvant therapies coming, they're going to be giving our patients or future patients advice on what to do. and we need to, educate them, involve them in the trial designs. That's where I think, Prosper was helpful, getting them involved early, because we're going to be sharing that. We still do a lot of surgery in metastatic patients. Everyone who's not poor risk, we still operate on. I know that's not the case in Europe, but the Carmina study has not really changed our practice as much as it has there. Surgery certainly is important.
Thank you, David. And then maybe just the last question from me. Do you think the ultimate treatment-free survival is achieved with cellular therapies?
It could be, but I'm not sure what the target is yet. You know what I'm saying? Like, I think there are CAR T-cell trials, for example, that are launching, and some of them, as known publicly, have focused on CD70, for example. To me, this all comes back to your data, or your institute's data. I think the most depressed I've ever been at an EIKCS meeting was when it was either Charlie or Marco Gerlinger presented the original heterogeneity data like 10 years ago at one, I think it was a meeting in Dublin. And when he sat down, I was like, we're not going to solve this problem. This tumor is too complicated, at the time we see metastatic patients. So what worries me about CARs, for example, is that they may be active in a subset of the tumor, but by the time we're treating that patient, there's probably multiple targets. There's probably, we'll see. I hope I'm wrong, but I do think it's worth exploring. It's certainly worth CARs, TIL therapy, bispecifics, all of those have a role to be certainly explored if we're pushing for more cures in the disease.
Wonderful. Well, I think we can't thank you enough, David. It's been a wonderful talk, wonderful discussion. Thank you to our audience for great questions. And thank you once more, David, for joining us. It's been a real honor to have you at the meeting, and we'll see you all tomorrow for more exciting talk.